out of your busy schedules to join us on our Zoom meeting tonight to discuss COVID in prisons. What I plan to do is, just for orientation purpose, spend maybe the first sort of half of my comments providing some orientation about jails and prisons in the United States, and provide some context about health issues in general. And then focus in on COVID and sort of bring us up to sort of where we are now. And if I do this right, those of you who know me know that I always talk longer than I think I'm going to, but my intent is to leave a good amount of time at the end for us to have discussion. So let me get to share screen and call up the PowerPoint. All righty. So we've already talked about the title. You've heard about my background. This is just so it's in the presentation. I began my correctional work in the late 90s in the state of Rhode Island, where I was primary care doctor in jails and prisons. Both the jail and prison systems in Rhode Island are all located in on one campus. The last 3 years, I was the medical program director. I then moved over to the state hospital, worked in a forensic psychiatric facility, and during that period, co-founded the Center for Prisoner Health and Human Rights at Brown University. It's now been renamed the Center for Health and Justice Transformation. Still going strong. I'm still involved with them. I was co-founder of a consortium for justice and health care at the University of California, which is less active now, but was a good collaborative of people throughout the UC system. As you heard, work for Physicians for Human Rights. I've done expert work in the Plata v. Brown case. That's a big, decades-long prison health case here in California. I'm currently the federal court-appointed monitor of the medical care for Riverside County jails, which will be relevant to some of what we talk about tonight. And I continue to work as an expert consultant for the Department of Homeland Security in the Office of Civil Rights and Civil Liberties. So I'd like to begin my discussion, particularly with students, asking the question, why should a doctor work in a prison? It's a question that I was literally asked over and over again when I first took a job in the Department of Corrections in Rhode Island. Rhode Island's a very small state. If you don't know about Rhode Island geographically would fit in Joshua Tree National Park. And the population of the whole state of Rhode Island is about 1/3 the population of the county of Riverside. So a small place where we all know each other. So I graduated from Brown, trained in residency there, done very well. So people really, my faculty and my colleagues were really quite surprised when I took a full-time job at very low pay, very low prestige at the prison. And they would often ask me why. So there's an old, we don't quite know if it's true, apocryphal story about Willie Sutton, the bank robber, who is always apparently was asked one of the times he was arrested, why do you keep robbing banks? And his famous answer, because that's where the money is. So I would say when people ask me why I went to work in prisons, why would I do that? And my answer always was because that's where the patients are. Indeed, if you know anything about health in correctional settings have some of the highest rates of disease you'll find anywhere in your local community, and they are often severely underserved in terms of professional services. So let's start with an overview of US prisons. The first term, you've probably heard it before, but we should get it out on the table, is the term mass incarceration. It's a term that's been used for the past 20, 25 years to describe what we do in the United States, which is unprecedented in the history of the world. The land of the free incarcerates more of its citizens than any country in the world now or in the history of the world. So for example, we hold in the United States 25% of the world's prison population, whereas we only make up 4% of the world's population, very disproportionate. You'll see variations of this. They get updated every few years. This is actually the most, not every few years, but every decade. Most recent graph I could find is still pretty close to accurate, but it shows the United States incarceration rate around 700 per 100,000. Depending on how you count it, it's gone as high as 1,000 per 100,000. It is coming down again. But look at how we compare to the rest of the world. And notice that Russia is the next line down. Russia actually, there was a period where Russia was higher than us, the 70s and the 80s, but we passed them out a long time ago. And in fact, they reduced their prison population pretty dramatically several decades ago. But if you compare us, to really the kinds of countries I think we'd want to compare us to, those would be, further down the list. Some of the European countries, look at United Kingdom or Italy or France, and you're seeing 100 to 150 per 100,000 in contrast to our 700. So again, this is more updated. This is 2016 at the far right. So finally, around 10 years ago, we did start to do things to reduce our jail and prison population, which is certainly a good trend. Obviously, it hasn't gone far enough for us to get to acceptable numbers. Now, I'd be remiss if I didn't just show you this, because when we talk about the rising incarceration rate in the United States, and that's the red line over this period, those who defend that say it did help bring down the crime rate. And so there is some truth to that. My context that I would provide to that is, I would ask us, at what cost? And were there other ways? And is it necessary, if you've studied statistics, and you have, that association is not causation. So it's not even, there are people who debate whether the reduction in crime rates is necessarily a result of high incarceration rates. But let's allow that even if it is, it comes at tremendous cost. Or it comes at tremendous financial cost. So this is 2014, 6 years ago. The US spent $80 billion on jails and prisons. That's more than the gross domestic product of many countries in the world. It's a huge number. Where I had been working in Rhode Island, the average cost per inmate in 2019 is $85,000 a year. And the cost of Supermax, that extreme isolation that's very controversial and harmful, that I oppose, is over $200,000 per inmate per year. In California, in 2016, the state was paying about $47,000 per year per inmate. In the most recent year reporting, 2018, 2019, it's over $80,000. I don't need to tell this audience that's more than medical school tuition, room and board, right? You think about where we're putting our resources. That says something about us as a society. Again, making that comparison of expenditures on education versus spending on detaining people in prisons. On the left, 1994 and 1995, and the tan is the spending for K through 12. The tan is 1994 and 95. The blue next to it is 2014, 2015. So you see there's a 30% increase in that period of spending on K through 12. But there's an 87% increase already from a much higher number in spending on state prisons. So again, this says something about us as a society. Specifically driving the costs are health costs. So the US spent around $8 billion a year on inmate health in 2011. The average per inmate per year in 2015 was about $5,700. But in California, due to decades-long litigation that went all the way to the US Supreme Court, we're spending $20,000 a year per inmate just for the healthcare or providing them. And I can tell you, because the litigation grinds on, that the court has still not ruled that even with $20,000 per year per inmate, the care has not been found to be acceptable by US constitutional standards. So really pouring a whole lot of money into a system that doesn't do a great job. We can't talk about jails and prisons and then the intersection of jails and prisons with health and health of our communities without talking about racial disparities. So on the graph here on the left is the share of the US adult population by race, 64% white, Hispanic or Latino is 16%, and Black is 12%. But the makeup of prison population is 33% Black, 30% white, and 23% Hispanic. Note then that the majority of people who are incarcerated in the United States are people of color. We also have an aging inmate population owing to longer sentences and the vestiges of the 3 strikes and you're out kind of laws that got passed in the 80s. So we have increasing numbers in each passing years of inmates who are over age 55. That's the yellow line here in comparison to the percentage increase in those under. And of course, the problem here in the topic that we will eventually get to of COVID is relevant because, right, we're most concerned about people and their vulnerability to COVID as they reach advanced stage. So do know that you think of jails and prisons, you think of younger people. And it's true in raw numbers, the majority of people who are serving time now are younger, but the percentage that are older has been growing for decades. Now, a point my colleague Jody, Rich, and I have been making for quite some time that we don't think enough people in politics or in public policy or the public understand is certainly doctors who don't work in corrections don't get this really critically important point. I guess it's about 10 or 15 years ago, we wrote a short little letter to the New England Journal making this simple point, that the majority of inmates in US prisons have an untreated or undertreated medical condition that may have contributed to their criminal activity. So I don't know if you ever thought of it this way, but owing to undiagnosed, untreated, or diagnosed but undertreated, or lack of resources in the community for treatment, all those factors, really failures of the health system, of the public health in the community, may be a significant contributing factor to the majority of people who are incarcerated. So that's just an important perspective to keep in mind as we think about this. And then, you know, on a related note to the last 2 points I just made, we can't think of the impact of incarceration, say, just in dollar terms, or even on the human cost of the individuals who are incarcerated. Remember, this has huge impact on communities. And I don't know if you've ever seen maps. You can Google them and find them that sort of are impact maps that show by zip code or by neighborhood. Some states even have them by neighborhood that show incarceration rates by a kind of address and neighborhood. It would not surprise you, I don't think, to learn that the incarceration impact is not evenly distributed. Obviously, we see greater impact on communities of color and lower income communities. And so the relative impact on stability in housing, stability in households for their economic security, and then related stresses and disorders from addiction to mental health, school attendance and performance of children, strength of family units and divorce and so forth. So these impacts on the community are profound. Like all traumatic or adverse experiences, they can have lifelong impact on family members who are affected. So remember, this is sort of like we're talking about the people who are involved with the justice system where they themselves haven't ever done anything that violates the law. They haven't been tried or convicted of anything, but they're affected. So also important to know, I alluded to this earlier, that infectious diseases are higher prevalence in the correctional setting for different reasons. HIV and hepatitis C are probably, in fact, we've looked at this and studied it, not highly transmitted in correctional settings. They are largely transmitted in the community. And as it intersects with the correctional population disproportionately over the last 30 years, 40 years, by means of injection drug use. But because that overlaps with a population that does see higher rates of arrest, we tend to have higher rates of these diseases in the incarcerated population. Tuberculosis is important. There's an intersection, and there was an intersection, particularly in the era where HIV was poorly controlled and less diagnosed. But tuberculosis in jails and prisons is important because it's easily transmitted in close quarters. Over the years, jails and prisons have developed very good protocols to screen for and try to prevent spread of tuberculosis in US jails and prisons. Actually, internationally, a lot of work's been done. That's important because it sort of set up sort of the infrastructure, as you might say, on how you handle an infectious disease. We've also had outbreaks in more in US immigration detention of measles, but also some jails and prisons. Certainly every year, influenza is an issue. And actually all the other, a norovirus, any of the infectious diseases that you wrestle with in the community, they're more of an issue in corrections owing to the close living congregate setting. And of course, now COVID-19. So getting to the COVID-19, this is a snapshot. There's a great website that I highly commend. A colleague of mine runs at the University of North Carolina, Chapel Hill, called the COVID Prison Project. That little logo is tucked down there in the corner. And this is a snapshot from their website today. It's a great website that gives you a lot of raw data if you're interested in COVID in correctional populations, and it's updated on a daily basis. But here's sort of their main dashboard. So where are we? It's February 9th, 2021, and roughly 2 million people incarcerated in the United States, 381,896 documented positive cases. Now remember, just like any other positive cases numbers you're reading, you do know, I hope, and understand, that's test positive cases. Do you think that's all the cases? Of course not. I think we all estimate that these figures may be even half what the true number is. California, in recent conversations with people in California system, the state system, estimate that by now half of their population has had COVID-19. So it really has ripped through jails and prisons. There have been 2,296, almost 2,300 deaths. The statistics regarding staff are definitely underestimates because staff aren't obliged, depending on setting, to report their COVID positivity. They just would give a sick note, for example, but they wouldn't necessarily have to say why they were out. And likewise, death reporting would be voluntary if it were related to COVID. So those are probably underestimates. This is a nice article. You can find it online for free. There's a publication called Issues in Science and Technology, and these are some colleagues of mine from Brown and other places. Jody Rich, who I've mentioned, Justin Burke, who is currently the medical director of the Rhode Island Department of Corrections. He's in other words, in my old job, a good guy. You can Google it. There's the title. This is a screen grab of the top of the article. COVID-19 exposes a broken prison system. It's a nice little, not article so much as a lot of graphics and statistics about COVID and health and incarceration. So I recommend you look at it. But I did steal his first figure, and it just illustrates the rates of COVID in the prison population, normalized per 100,000 again, versus the rates in the US population. So just as you can see, after about April, it takes off in corrections. And until this day, we have significantly higher rates of disease in jails and prisons, again, for the reasons that we'll elaborate on a little bit more. Just as you also know, I do work in immigration detention. They have struggled similarly. So here's their equivalent graph and notice that their numbers are actually embarrassingly even much higher, as high as 7,000 or approaching 7,000 per 100,000. And that's discouraging because one of the recommendations Jody Rich and I and others made quite publicly in high profile places, from op-eds in the Washington Post and other places, and but also in testimony before Congress and communications with DHS. The ICE population does not immediately represent a security threat if they were released to community, right? So you can make the argument that if someone's in for aggravated assault in a state prison, that people might have a legitimate concern that, gee, if you release them to reduce your population as a way of trying to reduce risk of COVID spread in a jail or a prison, might someone in the community be at risk of becoming victim of a violent crime? That concept just doesn't hold water when you're talking about people being held in immigration detention, largely for being in the United States without status, but not necessarily representing a threat to public safety. So here they've done a terrible job controlling COVID so far, and I think they could have done so much better. Here's California. CDCR is the California system, the state system. Here's there, again, you can look this up. This is also fresh data, and shows the statistics for the state. Really shockingly high numbers. By the way, this is just a state system. You may have read about the federal prisons, Federal Bureau of Prisons, Terminal Island and Lompoc also had huge outbreaks that are still an issue, but this is just the state system with the 48,000 total cases, over 200 deaths. So really terrible outcome in that system as well. So, you know, why? Why does COVID spread so quickly in detention settings? Well, this picture on your left here is literally from the state correctional system here in California, where they use bunked dormitory settings because of overcrowding. So it's congregate settings like cruise ships, like nursing homes, like college dorms. But compared to those other ones, the quarters are even closer and hygiene is poorer. There's also the revolving door aspect. So imagine, you know, you had a cruise ship or a nursing home, but you were cranking people in and out. This is particularly true in jails, where people tend to have shorter stays, are booked, may be released within a few days. So you're cranking people in and out of a high risk environment where they're likely to acquire infection if it's present, and then pouring them back out into the community. So remember also that COVID outbreaks in jails and prisons do not just affect the jails and prisons. Through staff coming and going and inmates coming and going, they can accelerate and they can become hotspots. We referred to them early on. We warned everyone that they could be tinderboxes that would then launch and spread and overwhelm local communities. Poor hygiene and public health measures are characteristic of our jails and prisons. There's barriers in access to screening and care related to resources and just poor practices. And you referred to my testimony before the Senate Judiciary Committee this past summer. I really was pained to make the point that I was deeply disappointed in the CDC's guidance for jails and prisons throughout this whole COVID period, because their advice was vague and very unhelpful. It set a very low standard, and it didn't follow even basic public health principles, as those of us who work in the field know. It felt to me like they didn't even consult anyone in correctional health. And as I said in front of the Senate Judiciary Committee, they may try to defend their approach, but it has been associated, as I've described, with abject failure. It didn't work. All right, so let's just go through a little quick exercise. This is copied directly from papers I filed. So a lot of what I do involves grunt work. I inspect facilities, I interview detainees, prisoners, and so forth. But I also spent a lot of time communicating with legislators, but also a lot of time communicating with the court system. So in Riverside, I'm the federally appointed monitor in litigation involving the jail system. And, you know, I was filing a lot of statements, trying to point out what I thought the county needed to do, and found similar statements in other cases throughout the country and within the state. And at one point, it occurred to me, as often does, you know, when we as professionals, especially technical professionals, interface with the public, we have to remember that they don't understand our jargon. So, you know, after some back and forth and the lawyers responding to what I was filing clearly weren't getting it, I created these little cartoons. So we'll just walk through them. They'll be so basic to you, but understand that the people, legal people and the political people did not get this at the beginning. And we were fighting over the need for them to test more aggressively. They weren't testing, they were doing symptomatic testing only and having an outbreak and with bad results. So, and we've talked about, you know, here's a typical module in most modern jails and prisons where you have cells. They can be single or they can be double typically, but there's a common area that everyone shares in each mod. And they can hold 30, 50, 60 people. So, you know, think of this from an infectious disease perspective. This is not a good setup. So here's what we were dealing with, because we already, by the time I was being consulted, had our first cases in the Riverside County jail system. If you remember that period, in the early period, sadly, we lost one of the sheriff's deputies and one of the inmates in the early period. So we knew we had a problem, and they were testing people who were coming down with symptoms, and they were finding quite a few cases. So they knew they had an outbreak. They had staff represented by the little police caps here, and the inmates are the dots. The red ones being the positive, the black ones being the tested negative, no negative, and the white dots and caps, we don't know. No one tested them yet, and they're not symptomatic. All right. So where we were is the jail had said, and this story, by the way, played over and over again, so many facilities. The jail said, we've identified the people were infected. The officer who's infected is at home. The infected inmates are now in isolation and quarantine. And then we tested some of the people who had been in their company, and we identified a few more cases, another officer, another. And this is where we were. And across the country, wardens were saying, we're done. Everything's under control. We've got the situation in control. But I was like, of course, as you would understand, focused on the white dots. We knew by this point, this was early in the spring, but we already knew that asymptomatic transmission was a big issue. And I was pushing hard for more aggressive testing. And so here's in scene 4, where I said, this is what they think the situation is. They've assumed that all the white dots are negative. So this is the best case scenario, but it's very unlikely. And in fact, that the scenario that was really present, if we knew everyone's status, was probably something more like this. So you think you've isolated the problem, but you haven't. So anyway, just to walk you through that exercise as a way of getting you to think about how you communicate with people who are not public health experts, drawing pictures, cartoons, whatever it takes. But this actually turned out to be very effective. After we filed this with an explainer, everyone kind of went, oh, okay, now I see what you're talking about. And actually, a little bit later than I would have liked, Riverside finally undertook a very comprehensive testing program, did identify some significant number of cases that were out in population that they hadn't identified before. And they did for a while get things in control. Unfortunately, as you've all been following the news, that control didn't last forever, and they've had some recent outbreaks as well. But they're testing very aggressively, and they're trying to be more proactive at this point. So again, more pictures from sort of typical jail units. So what are the tools we have to fight COVID in detention settings? Well, early on, one of the first op-eds Jody and I wrote, Jody Rich and I wrote, called for significant and rapid reduction in population, because social distancing is one of the techniques we all recommend, but you can't socially distant when you're in a confined space. But you can sort of socially distant if you get your populations down low enough. And also, if you think you're going to isolate and quarantine or cohort some groups that might have been exposed, you need space to do that. Jody uses that nice little example of those, well, if you've ever played them, those little puzzles that have the one square that's open and you have to move things around. Well, if you're trying to rearrange your population, you need some empty space to do that, so you can shift people around. You need to let some population go. That advice was followed to some extent and variably throughout different systems, but in some systems they didn't do it at all. The Federal Bureau of Prisons, for example, hardly reduced their population at all. And when I gave my testimony, I had to sit there uncomfortably while one of my colleagues, who's medical director of the Federal Bureau of Prisons, and his director, Federal Bureau of Prisons, were challenged aggressively by Republican senators for not having reduced population when there were already known large outbreaks in the federal system. As I mentioned, Lompoc and Turman Island right here in California being leading examples. Hygiene, hand washing, PPE. I should have added here regular education of staff and inmates on how important those things are. Screening, testing, isolation, and quarantine, which involves testing. Initially, if you go back and review the history, testing is available, but most correctional and detention systems waited way too long before they deployed testing. It was sort of a don't ask, don't tell approach. Decreasing transfers is important. If you know the California story, they are still trying to explain why they transferred people who were positive with COVID from one facility to another that resulted in an outbreak. This has happened in the immigration detention system too. And then now, most recently, of course, vaccination of both inmates and staff. So vaccination, where are we in Riverside County? So it's the interesting thing, you know, there, as we all know, we've been following, there's not a good national plan. What you tell me, what are the ranking priorities for the COVID-19 vaccination? And if you give me 12 different answers, I'll tell you there's actually probably 100 different answers, because the CDC has a ranking system, but as late as the last administration, it was every local jurisdiction for itself. So you can look up, again, easily find Riverside County's ranking system. That's what I've quoted from here. The staff, the officers and staff who work in Riverside County jails are phase 1A, tier 2. So they are being vaccinated now as we speak. Inmate vaccination, credit to Riverside County, because I at least mentioned them specifically. A lot of plans in other states and other counties don't mention inmates anywhere. They're in Riverside County are 1B tier 2, but I can tell you the good news is, even though we haven't gotten to that tier in the Riverside County plan, with our encouragement, they did prioritize people who are high risk. So older inmates and inmates with medical conditions would make them susceptible. So vaccines are being offered to those high risk folks in the Riverside County jails now as we speak. So that is my just sort of orientation material to sort of set up where we are. And now I would be happy to entertain any questions.